of the total kids who will be diagnosed with a particular diagnosis who have been diagnosed at that age. So for example, the blue triangle, light blue line on the left is ADHD. By about age 6, maybe 90% of kids who are going to be diagnosed with ADHD have been diagnosed already. So the red line, back for 1 second, I apologize.
Right.
So the red lines are the anxiety disorders. So the dotted red line more to the right is a generalized anxiety disorder, OCD and panic. They're lumped together here, but those broadly show up later in adolescence than things like the phobias and separation anxiety, which are more to the left at the younger ages. Okay. And this is important because anxiety in childhood predicts later psychopathology in young adulthood. So depression, ADHD, bipolar disorder, substance use disorder, learning disorders, and eating disorders have all been found to be predicted by early childhood anxiety diagnosis. And treating anxiety helps. So untreated childhood anxiety is associated with young adult impairment in social, educational, occupational, mental health, and physical health outcomes. So basically, across the spectrum of functioning, untreated anxiety is a risk factor for poor outcomes. So then the question becomes, what is an anxiety disorder versus what is anxiety? So we can think very, very broadly about, that subclinical anxiety is, a predisposition perhaps toward more anxious temperament, but not necessarily a clinical disorder. Kids who have mild clinical anxiety often benefit from therapy. Kids who have very severe anxiety have benefit from therapy meds. And of course, there's always the gray area in the middle where therapy is a good idea and meds may or may not be helpful or indicated. And then next slide.
Kelly, there's a request for you to speak a little louder.
Oh, thank you. I will move closer and speak louder. Thank you for saying that. And so the clinical versus non-clinical line is really the same as in throughout the DSM, that there needs to be a clinically significant distress or impairment in social, occupational, or other important areas of functioning. So whether it's a clinically significant impact on domains of functioning is important. And of course, I'm using this picture of the coronavirus as a proxy for all of the stressors that happened during 2020, but the entire population has moved to the right on this graph, given everything that's going on in the world. And kids are no exception. So next slide. I asked a 7-year-old to draw what is it like to go to distance learning every day, and this is what he drew. He's sort of like exhausted and plodding toward his computer screen. And this is not at all meant to disparage the amazing job that our teachers are doing in these extraordinary circumstances. Just that kids feel the same stress that everyone is feeling right now, and it's a very difficult time. So, whether the anxiety would be present without the pandemic or without everything that's going on in the world, perhaps is not the salient question. I think the salient question is, has it moved into a clinical level of anxiety, and therefore is it something that we can help with intervention? Okay, next slide. So childhood anxiety disorders are very common. This is just some CDC data that there's increasing total incidence when you add up all of those 9 diagnoses, increasing incidence throughout development, but up to about 11% by the time of 12 and 17-year-olds have an anxiety diagnosis. And so a bit more common than depression diagnoses, and close to behavior disorders here is ODD, ADHD, and conduct disorder is what they lumped into the yellow categories there. So it's comparable frequency. Okay. And then comorbidity is also common. This is a DSM-4 slide, but it was pretty, and it's about like the DSM-5 data, so I used it. If we look across the whole population of kids and look at what categories of DSM diagnoses the children have, so mood disorders, anxiety disorders, ADHD, etc. Most of the kids who have a diagnosis, 58% of that kids who have a diagnosis will have just one of those categories. So 27% will have an anxiety disorder. But comorbidity is common among kids who have one diagnosis. The 24% also have another diagnosis, and 11% have 3 of the diagnoses, etc. Okay. So I just wanted to briefly go over a couple of screeners that can be useful clinically. The SCARED is free and available online. There's a form for the child, which is the screenshot that I've given you, and a very similar looking form for parents. At the very top, it says child version, and the other one says parent version. It's 41 questions, so it's a bit of an investment, time-wise and scoring-wise. But at the end of that, it gives a total anxiety score, but also domain scores for different types of anxieties. And that can be very useful diagnostically and for tracking response to treatment. So it gives panic and somatic, generalized anxiety, separation, social phobia, and school avoidance scores. However, the scoring is a little bit cumbersome. So if you can see on the far right column on the screenshot that I've had, there's those little letters PA/SO, SCH, etc. Basically, what you need to do is add up, for example, add up the score for item number 2 with the score for item number 11 and all the other questions that are about school avoidance, and put that total on one line, and then do the same thing for all of the panic ones, etc. And that can take a little bit. So next slide, please. Our colleagues at Pitt have very helpfully made an Excel file that does this automatically. So that link on the left there, I have a screenshot of that website. And if you go down to what's in the red box there, that is an Excel file that comes up, and you just enter the 1, 2, 3 item responses, and it'll automatically generate the different domain scores. And it's just a lot faster than adding it up by hand. And then another screener that is less detailed, but probably more feasible in some circumstances, is the GAD-7. So again, just freely available online, and you just add up the totals and get minimal, mild, moderate, and severe anxiety scores. And that is my last slide.
Kelly, one question that had come up when we were talking to the team leaders is, when do you use these screeners? We're not routinely screening for anxiety. So when would you pull out one of these anxiety screens and use it?
I will defer to my colleagues as well. I think certainly when there's a clinical suspicion, I think when there's a family history of anxiety, I think routinely doing a SCARED at every well-child check is probably not going to be feasible. But if there's starting to be a lot of externalizing behavior or school avoidance or that sort of thing, it can be useful to do to screen.
Any other comments others have, or questions from others in the group on Kelly's presentation before we move into the clinical case today? Feel free to.
I've been noticing that at well-child visits, the pediatricians are usually asking families about how everyone is dealing with the pandemic. And parents sometimes are reporting on kids showing increased anxiety. And so that might be a good opportunity to introduce one of the screeners.
Any other comments or questions?
Would you rely on a screening to actually like diagnose, do those numbers of scales, like if I were going to like put a diagnosis in the chart, the parents reporting anxiety, but on the screening, it's like 4 or whatever it is. I mean, to make a DSM-4 diagnosis, like it's not just the screening, right? You're still gonna,
It's like anything else. You treat the child, not the test, right? So
exactly.
you do a clinical interview, you go through the DSM criteria, and it's a supportive data, but it's not a diagnostic thing. It's a screener.
Mhm.
Yeah.
A lot of times, this is Safani with Katie. I would do a scared when I find that the young person is not improving with treatment, especially if I assumed this was depression and I was treating it with depression, and they were going to therapy and they're not getting better. And then we uncover significant anxiety, and that sort of changes the type of therapy I prescribe or I recommend. That's when I usually use it.
Yeah, I think we also find that, again, the scales are very helpful, again, for measuring improvement over time. Whereas for the DSM-5 kind of diagnosis part that we're thinking, it's more like, well, wait a minute, do they meet a certain number of symptoms? And is it really impairing their functioning? Both with family, with school, even though right now that's a little bit different than it usually is. And again, in their peer group.
Mhm. And Goldstein is bringing up the point, how about the GAD-7 at well-child checks? Since that's a shorter, easier tool. Are anyone using them at the GAD-7 for well-child checks?
I use them if my PHQ-9 is high.
Mhm.
And my daughter pointed me out to that. She says, you screen for depression, but you don't screen for anxiety. And I was like, yeah, you're right.
Mhm.
She was onto something.
Yeah.
I'm Julia Richardson. I'm licensed clinical social worker from the Virginia map. And I just want to chime in here. We did anxiety last month, and the GAD-7 is a really good one because it's so quick to score. It's only those 7 questions. So it's really great if you're doing a PHQ-9 to also screen for anxiety with the GAD-7, because it's a lot of comorbidities, like Kelly said. Practically using the scared, I'm hearing from providers that it's really helpful if you've got a telehealth appointment, or if you realize that you need a scared after the fact, to send it over to them in the right email and then have them score it, or have a parent score it, or even have a nurse call and score it with them, and then give you the result, give you the number, so that you're not taking 15 minutes out of your 15-minute appointment, just doing the one measure. It's also really important to remember to try to get a baseline. So if you're thinking that they probably have anxiety, or you've identified it with the GAD-7 and now you're going to start treating, remember that scared is better to continue using through treatment. So if you're going to try a medication or therapy to assess whether or not it's a statistically significant change and actually a valid improvement, rather than just the subjective, we want the objective and subjective together. So it's a really good idea to have them do a scared, even if they did a GAD-7 and you're going ahead with treating, because then you can evaluate, in 4 weeks if the treatment has been productive enough, or if maybe it's not, and now you need to change courses.
Thanks. That's a lot like your point, Stephanie.
Yes. The question, though, in regard to the scared, the child and the parent one, when do you stop doing the parent? Because a lot of times I have teenagers where a mother would document that there is no anxiety, and then the child's screen is totally off, like very high. So how valuable is the parent? I mean, what is the age where you wouldn't even want to know?
So I think the scared is officially approved for ages 8 to 18, first of all, which I think Dr. Schwartz was asking about. I think it to some degree it's dependent on the child. For a quite alexithymic child, I'm an autism specialist, so a lot of my autism kiddos, the scared is not particularly valid, and the parent report is helpful. Conversely, for our older teenagers who may be internalizers or not reporting to their parents how they're feeling, the child self-report is going to be a lot more valuable. So I think probably clinical judgment, but also a little bit of for the older kids and who may be more less forthcoming with their parents, the child report is going to be more valuable.
Great. Let's move on then. Katie, you have a case